So my name is Dr. Alex Levchenko. I'm going to be talking about orthobiologics in regenerative medicine. This is about a 2-hour talk. I'm going to try to do it in 10 minutes. Okay, I have my timer going. So here we go. All right, so I'm an interventional physiatrist at ONS. We do most of our injection with image guidance. I'm board certified in PM&R, physical medicine and rehabilitation, as well as pain medicine. And I'm also certified in regenerative medicine by American Board of Interventional Pain Physicians. NIH definition of regenerative medicine is the process of repairing or replacing damaged cells, tissues to restore normal function. So we use cell therapies, but it's very important to know how to generate the correct type and quantity of the cells, as well as where to inject. So one thing important to know is that this is off-label use we are allowed to do as physicians. There are no FDA-approved treatments in regenerative medicine. We're going to be talking about autologous orthobiologics. Autologous means from the same person into the same person. So PRP, bone marrow aspirate and concentrate, as well as adipose tissue concentrate. So what is platelet-rich plasma? It's an autologous, usually centrifugated peripheral blood with platelet concentration above the baseline. It decreases the inflammation. It increases cell metabolism. And it has a paracrine effect, meaning it actually attracts the MSCs, which is mesenchymal stem cells, to the site of the injury. So quality and quantity of PRP depends on the preparation protocols, and are very difficult to standardize because there are very many different ways to prepare the PRP. Giusti et al. In 2009 determined that the optimal concentration of the platelets for the stimulation of angiogenesis was 1.5 billion platelets per milliliter. And then the Banzel and Associates in 2021, they did intra-articular injections of PRP into the knees, and they determined that having 10 billion PRP total cells per day injected sustained the benefit at 1 year. Overall, it's safe and effective with no known systemic adverse events. The most common potential side effect would be localized swelling and pain. Risk of infection is similar to any other injection, and as you can see, the very, very low rate of major complications. How does it work? Well, it works either through the classical healing cascade or as well as the angiogenesis cascade by pretty much restoring the blood flow to deliver oxygen and nutrients to the site of the injury. Generally recommended to hold the NSAIDs and steroids for 2 weeks prior and after the injection. COX-2 can be allowed, right? Interesting point that actually I didn't know myself. Acetaminophen decreases platelet aggregation, so it's better to stop that as well if possible. Same goes for cannabis. I have a lot of different studies that I cited. We're not going to be able to go through all of them, but pretty much there are a lot of randomized control studies, meta-analysis, and systemic reviews available and have been done on the use of the platelets. I'm just going to skip through that. Skip through that, and we're gonna, this is interesting, so there is no equivalent in the US, but there is the European Society of Sports Traumatology and Knee Surgery and Arthroscopy who actually did put the recommendation for the PRP, and they feel that PRP is safer and non-toxic over the steroid injections. And in fact, they actually even recommend using the PRP for an acute inflammatory knee as well, not only just the chronic knee OA. So what's the bottom line? So the bottom line is mild to moderate knee OA, intra-articular PRP is more efficacious than hyaluronic acid or cortisone injection. However, if you have a bony edema, considering intra-articular as well as intraosseous, injection provides better outcomes. So severe knee OA, you got to think about, again, intraosseous and intra-articular PRP or bone marrow concentrate. Now, how long does it take to improve? With intra-articular injection, usually takes 2 to 4 weeks. With intraosseous and intra-articular injection combined, 3 to 4 months. So hip OA is a little bit different, a little bit tricky. Can consider PRP, but typically hip OA does not respond well to PRP, but does respond to bone marrow concentrate injection. And usually you would need to think about an intraosseous injection for that. It has been shown beneficial to be in mild to moderate first CMC OA, Dr. Vitali, carpal tunnel syndrome, For the gluteus medius and minimus tendinopathy, we call that a lot greater trochanteric bursitis. Most often than not, it's not actually bursitis, but tendinitis. More efficacious compared to steroid injection with longer relief and sustained benefit at 2 years. And you should also consider actually follow-up shockwave therapy with that. It shows an additive beneficial effect. All right. So lateral epicondylitis, lots and lots of studies, systemic reviews, meta-analysis. This particular one said both the leukocyte rich and leukocyte poor were effective. Doesn't happen overnight, right? It takes 1 month to get the benefit, 50% better at 3 months, 60% better by 6 months, 80% better by 12 months. And interesting enough, so they did the, repeated MRIs in the study, and they saw changes on the MRI, improvement up to 24 months. Takes time. That's the bottom line. Another meta-analysis. This one looked at leukocyte rich versus leukocyte poor, and actually said the leukocyte rich was more beneficial. And I think that's the general consensus in the field that leukocyte rich is better for the tendinopathies. Works in plantar fasciitis. Achilles tendonitis, good results in combination with eccentric training. So again, this was an RCT. So what's the bottom line? So PRP for tendinopathy works really well for the tennis elbow, plantar fasciitis, good results with rotator cuffs, hamstrings, glute med, so trochanteric bursitis. Questionable, not so much questionable, but equivocal results with Achilles, quad, and patella tendon. What's the ideal concentration? Interestingly enough, it actually maybe depends on the age. So someone who is younger than 50 years old, you want to concentrate by about 5 times. Someone who is older than 15 years old, so the healing ability is a little bit diminished. Actually, the sky is the limit. How long does it take? 3 to 4 months for tendon improvement. This can be painful injections. If you're injecting into the tendon, they can be painful. So you want to anesthetize. Ropivacaine is preferred. It's less toxic than lidocaine to the tendon cells, and you can even consider doing a nerve block for more comfort. So it is less effective for the tears, right? So less effective for partial tendon tears, except the plantar fasciitis. So it's also beneficial. So there was a study on the ulnar collateral ligament tears, partial, and twice was repeated, same outcomes, was efficacious. 32 out of 34 patients returned to the same level of activity at 12 weeks. Other ligaments, ATFL, largely negative, MCL, largely positive. So spine, moving to spine, intradiscal PRP. Discs are vascular with poor healing capacity due to that. Late Greg Lutz at HSS, he did a double-blind randomized study in 2016. They injected leukocyte-rich PRP, 5 times the concentration. 60% of patients got better, and they increased the concentration to 10 times. 80% of patients got better. So there is a risk of discitis. It's very low, but it's not zero. And it's much lower with the use of the leukocyte-rich PRP. In fact, in their studies, when they used leukocyte-rich PRP, they had 0 rate of discitis. Can you do an epidural? Yes, you can. You got to use leukocyte poor and RBC poor. Otherwise, you're going to have a major flare-up. You can inject facets. You can inject the side joints. You can do iliolumbar ligaments. Here's a case series for the ultrasound-guided PRP injection into the side joint. Better outcomes at 12 months. Still better results at 4 years. Piriformis syndrome, ischiofemoral impingement syndrome. We're going to shift gears and go into stem cells right now. So embryonic and non-embryonic, right? We're really going to concentrate on non-embryonic stem cells. So bone marrow concentrate. I'm going to skip through that. MSCs, that's really what we're looking for, right? So mesenchymal stem cells, the advanced tissue repair. However, in bone marrow, it's only 0.01 to 0.02% of the total bone marrow cell volume. Usually the most common site to aspirate is iliac crest, most abundant of MSCs. What's the bottom line, right? So OA, KL 1 to 2, PRP. 3 to 4, BMAC or adipose works better. If bone edema, consider intraosseous and intraarticular PRP or BMAC. And it's going to take about 3 months to know significant difference. So with more advanced spine degenerative changes, BMAC is considered to be more efficacious than PRP. However, there's a higher risk of discitis, still below 1%, but it's definitely higher. However, a recent 2024 study in intradiscal PRP versus BMAC showed equal efficacy at 12 months. So this is an interesting study. So this was actually a 15-year follow-up. When they did, they had 60 patients, 120 knees. They injected half of them with intra-articular BMAC, and the other half was intra-articular and intraosseous BMAC. Tracked them for 15 years. At 15 years, 70% of the intra-articular went to TKA, total knee replacement, versus 20% who had intraosseous ended up with the TKA. So it appears to be a protective effect and slowing progression of the osteoarthritis. So this was for the hip. So they did the bone marrow aspirate and injected by 12 months. 80% of grade 2 had improvement, 75% of grade 3. And as you can see, grade 4 had the least, 57% of at least 30% reduction in pain by 12 months. So adipose tissue concentrate appears to be as efficacious as the bone marrow. Interesting thing is that the adipose tissue has 15 to 20% of MSCs, right? So compared to less than 1% in bone marrow aspirate. However, I'm going to skip through that. BMC, so bone marrow MSCs have been used and studied the most extensively, and it also appears to be superior with osteogenic and chondrogenic differentiation. So there are plenty of literature supporting the use of orthobiologics. More studies going on right now. So an interesting thing, if you never heard of Brian Johnson, so he is the guy who decides he wants to live forever, right? So he's doing a lot of experience on himself using orthobiologic in the longevity medicine. So if you want, look up his Instagram. And that's it for me. 11 minutes. All right.